Her occipital ridge, found tenderness, so he's putting in.
Until you touch the bone, just feeling it, not scratching it, just touching it.
Gallbladder 20, occipital ridge, putting in. He's injecting as he goes in, he's injecting as he goes out. She was tender.
Mantiene mucha atención, hacemos un transfer. And she maintains the pain along this side here. We make that transoccipital blockade that we saw this morning in the picture with death pressure. Like it?
They must have a pipeline from Austria right over to Colombia with the Xylem Mill. We got it on tap.
We bring in drugs.
Laid a quaddle at the superior medial corner of the scapula is a real common area. So they laid a quaddle there at each spot.
Pain in the back is less. There's still congestion.
You still feel heaviness.
I feel heaviness. There's still.
She has one very apparent. You have one very apparent lesion.
Okay, go
You have a very perfect face. Could you turn around and maybe you shoot her face so everybody can see? Because if I tell you, it doesn't have as much value. She has a very nice, symmetrical face. Dr. Dookie, of course, got it immediately, and it's as plain as the nose on her face. Shoot her straight on, please. Very straight on. Well, it's hard to sit. Can you shoot her very? And would you look straight into the camera? There you can see it. Trace the angle of her nose down. So in the bridge of her nose, right down, it deviates. So I would suggest that she needs a nose. Well, we neural therapy her nose. So if you want to lie down. Well, it's done externally, and the doctor does the same little It's me. They're not nice when you get them. Okay? That's optional. But really, it's just like a pinch, and they only take a few seconds, and as soon as they get done, you start having your effect. You might have a little bit of runny nose, or just but it's just pink. So it's just seconds to get them done. And we get, no, but really, you want to change the deformity, and we'll show this on my slides tomorrow. But you won't change the deformity, but it really helps open them up.
So why are you doing this?
Because we haven't cleared, we're trying to go for a total clear.
Okay,
This lady's had pain since 17 years of age, even 14 years of age, and she's at least 18 or 19 now. And we're just trying to go for a clear, that's all. Yeah, she's all of 30. Probably 30 and a half. Okay, lie down if you would. Could you just hold that now?
Why aren't trigger points chased in a trapezius?
Well, I think trigger points are, Janet Trubell really tries hard, but those are really more superficial type lesions. I think this is a much bigger, when you get into a neural therapy concept, a homotoxicology concept, and a reconstructive therapy concept, you're at very much a more deeper core level of healing than doing triggers.
So muscle trigger points are more temporary.
It's more of an outer shell. we're going for the mother load here. So, put your arms down at your side. And one, two, three. Okay, touch your nose, please. No, like this. 1, 2, 3, release. Okay, now try real hard. She wasn't ready, right? 1, 2, 3, release. There's no bite. Now let's go back to see how Dr. Arturo's thyroid did. So touch the thyroid. Both hands. Do both. 1, 2, 3, release. Okay, touch your pelvis now. Yeah. 1, 2, 3, release. And touch your other pelvis. 1, 2, 3, release. And touch your nose again. 1, 2, 3. Okay, no bite on the nose. I don't think you have
Bite on the nose.
You lose.
So what, and that's just because the nose is a structural asymmetry.
If you see something and it's not perfection, it's a possible lesion. And she's got a very excellent face. And
Can I ask you a question?
sure.
How heavy-handed are you?
Well, this is a 30, and so it's a plastic surgery movie. And so I have to just close your eyes.
I'm used to my dad and, handsome. I'm
Well,
just checking. I
Let's put it
watched
this
the
way.
films.
Let's put it this way. Feel this callus on my finger. And that's how many injections I do. I do this every single day. So it'll be nice. But when you do a nose, the result will be nice. But a lot of the noses you can pick up by looking at this way as a patient easier. And just looking and see if you got some boogers up there.
So what happens with?
But actually, she's symmetrical from this way. She's quite symmetrical. If you look at her there, she looks quite symmetrical. But looking at her straight on, you can see we had a deviation. So she ran into a door or something.
But usually you'll get a depressed zygoma, or one eye is higher than the other, and
Yeah,
what happens
that's
then?
more full. You'll see that on my slides tomorrow.
You go chasing all those things as well.
Well, yeah, you chase what you find. Now, where you usually want to go on the nose is right where the cartilage starts, the osseous cartilaginous junction. And you just put a pink on each. A pink is what I call it, like maybe a quarter cc on each side. And generally, they're tender there. Does that hurt a little bit? And generally right there. And so just when you want to go into mouth breathing, sure you're there. Yeah, there. Well, just anything with the nose.
It's interesting that in the microcystin, that's gallbladder in China's nose.
Yeah.
Nose point. She had one gallbladder.
Okay, so very simple. You did great, sir. Touch your nose down. Okay, 1, 2, 3, release. Okay, why don't you sit up and see how much headache you have left?
Tell us
She's dropped a couple of pounds, the headache's gone.
This is for CNN, okay.
We're seeing it.
Has a congestion change.
It's changed, it's less. No, it is, there is less. There is less. I can't say that it's totally clear, but I've had it for so many years. A long time. We've been working on it for a long time. But it is definitely better. The head pain is definitely better. I think the pain is gone. I still have stress pain, if you want to call it, or tension pain in this area, but like I say, that's something I've had for many, many years and is aggravated by my job.
You have been very brave. I'll give you this here.
Alberto, was she as tight up there as she was? Can you touch her shoulders?
Is that gallbladder 21?
It's much better. There's still some there, she said, but it's...
Why don't you put them on that?
Well, he did.
Is it the same as before? I am pressing much harder than before.
We go for a total clear. I go in her mouth next, because she's probably got some stuff in her mouth.
She has a lot of teeth.
Finger exam, you've been finger examining your mouth? Well, she might be clear, but a lot of times find it in the mouth. Consider the scar. And then you brought up a good point this morning about earrings, and that's Dr. Hopper. The earrings tend to be more of a factor if they don't have a lobe, if they have a attached earlobe. And she's kind of like in between. She's got a little bitty cute earlobe there. So these ear holes, you might want to treat these ear holes on both sides. The ones that have the detached have less of a problem, but if the ear just goes right in and attached, I find that those ear holes tend to be more of a factor. I had to look at a chart. I had to look at my chart for a
No. My dad's
Gary
dentist
doesn't do that.
So we're taking a break for what, a half hour yet?
20 minutes.
20 minutes, so we'll start at 5:20.
Okay.
Thank you.
Yesterday and today, we thought it might be very useful so you can take something home with you to give you a little insight into something that you will be able to find in your yellow Neil Bible on page 15. This is called the autosanguis dilution therapy. It was Gary maybe who said the other day that if you would all take the time to go through this here, which I must admit is very difficult because it is written in Yerglish. It is, I mean, I know a lot of books that are much more fun to go through, but this is, we call it the Bible because there is so much knowledge in here. And one of the things that has been talked about very little, has been overlooked and has been not paid the necessary attention to, is to the autosanguis dilution therapy. As in many other things, we started working with this autosanguis dilution therapy many years ago because somebody who knew Reykjavik said to us, try to mix blood always, you know. If you do an intravenous injection, let first some blood come into your syringe, so you have a reception committee coming out of the body, and then you chase it again into the vein, and it's gone. He was right, you know. That reception committee, represented by a couple of cc of blood, you know, is very important because once the blood comes out of its circulation, hermetic circulation, an inflammatory process occurs. And that inflammatory process, and we know it now why, is the premise for any curative step. Blood has been, in all mythologies, has been considered as the carrier of the soul, as the carrier of life. You might remember that Goethe, in his Faust, he says at a given moment, blood is so special, a very special sort of juice. So blood has had always something mystic about itself. We know that the old Chinese doctors used to make with the Chinese hammer, with the little punctures, they used to make a lot of extensive hematomas at the skin level, causing microbleedings at a dermal level. They knew why they do it. If we observe this kind of procedure by the Chinese, this is a autohemo or an autosanguis treatment with a Chinese modification. They also used to cause extensive hematomas because experience had shown them that in chronic inflammatory processes, the reabsorption, the slow reabsorption of the hematoma was the necessary premise for fantastic cures. If you think of that, you know how important nowadays it is when you inject a patient and you end up causing a hematoma. You have an auto-nososed reabsorption process. And as we go on with this little chat on the blood, you will see how many elements you will be able to find or to re-find in the blood that are of curative importance. In the old documents of Ebers of the 15th century before Christ, we can read that the noble Egyptian families, the blue-blooded Egyptian families, used to bathe in human blood. I mean, that was a sort of an expensive sport, you know. But that there was the belief that blood, since it was the carrier of the soul and of life, has to transmit something. This bathing in human blood in the Middle Age was also recommended for the lepers. There is an old story, medieval story, the German mythology, which said that there was some very important gentleman in the Middle Age who was punished by God with a horrible leper condition, and he was visiting a very famous doctor in Salerno in Italy in those days, and that doctor said to him that the only way he could get cured of his disease, incurable disease, was by drinking the blood of a virgin. And the story keeps on saying that a little peasant girl, very beautiful virgin, sacrificed herself for that gentleman and offered her blood. God then accepted it as a fact, and that he saved the life of the little girl, and the gentleman could drink this blood, and he was cured from his disease. Many mythologies, many old stories that are passed along by traditions carry a lot of information on the blood. There is documented about in the first half of the 16th century, the first documented references to rejuvenation treatments done with human blood. So if there is so much talk about it, there has to be something about it. Let me just give you a little chronology, historical chronology here, because it just for general education, it gives you a very good insight on how it has been handled. In the year 1615, the first documented rejuvenation treatments were made with direct blood transfusion from vein to vein. In 1809, there was a long time where you don't have any kind of references to it, and in 1819, the first transfusion of venous blood was made using a conventional syringe like we have right now. Then it was in 1874, the British William Highmore defibrined blood of a lady who had just given birth, warmed it up, and applied it in transfusions. I don't know if you have read the newspapers lately. Something happened in Atlanta, in a hospital in Atlanta, where they have been extracorporeal. They have been warming up an AIDS patient's blood and just giving it back after it had been exposed to 42 cc, right, great degrees. more or less.
115
Fahrenheit. Centigrade is 42. More than that.
40 is
52.
Yeah,
52, yeah. Okay. They're trying to look for something with the blood, you know. And you will see later on why there might be some truth to it. I don't know if that's going to be the way that they should select, but there is a growing interest in blood. In 1876, the surgeons decided to leave some blood in the surgical scars because they came to realize that the formation of scars was promoted much faster if they left a little blood in the scar tissue, in the cut. 22 years later, in 1888, two Swedish, Elfström and Grafström, were the ones that came to perform the first auto-sanguis treatment in a strict sense. They diluted blood with saline solution and re-injected it in cases of pneumonia and also in cases of tuberculosis. The very well-known homeopathic physician, August Beer, who was the teacher of Dr. Reykjavik in Berlin when he became a homeopath, used to inject blood in fractures whenever the fracture itself had not caused a hematoma, because he had found out that the presence of that hematoma helped the welding process of the bone much faster. So in minor fractures, when there was no lieu to create a hematoma, he just took blood out and injected it between the two ends of the fracture to accelerate the welding process of the bone structure. In 1912, it was Novotny who really gave it a boost to the autohemo treatment in all kinds of infectious diseases. And starting as of 1913, a German of the name Spiethoff started using and documenting the use of blood of the patients, of auto blood, in all kinds of dermal or skin diseases. Since then, the manipulation of blood has been present mostly in the alternative medical practice. Maybe the most important work on treatments and on the importance of blood was written by Hans Haferkamp, again another German, around the 50s, in 1951. And that's maybe why this type of treatment is gaining again a very substantial importance in the medical practice, in the alternative medical practice. There has been a sort of a back or a certain resistance in the last couple of years of working with blood because of the AIDS fear. I remember that 10 or 12 years ago, we used to work massively with blood doing the transoxygenation therapy, HOT, which is just taking 50 or 100 cc's of blood, exposing it to ultraviolet light, and then re-injecting it intravenous to the patient. Ozone therapy has been used massively in the last 2 or 3 decades, also getting blood out in a vacuum, in the vacuum injecting 50 or 100 cc of very low gamma ozone, that is a mixture of very high quantities of oxygen with a little ozone. You still can perceive the smell of ozone, and that blood becomes like a Marlboro box. I mean, it becomes that dense blood becomes or turns like if it was an arterial blood. So all these treatments with blood have been very well known, allopathically speaking, in furunculosis. I remember when I was 10 years old, I used to suffer of furunculosis around my knees, and I remember I had been just exported to Germany in those days, and they took me to a conventional physician, dermatologist, I imagine, in those days, you know, and they just took blood out and injected it from one bud, from the vein into one bud and to the other bud, and after a couple of weeks, my furunculosis had disappeared. The same thing was used in the case of profuse warts, smaller warts. So the other side of the road also has handled blood somehow or other. One of the important things is to understand that when we deal with the patient's blood, to give it back to the patient, somehow we are dealing with some kind of cell or minute cell therapy. Why cell therapy? Because of the ingredients that we have in the blood. We saw it in our basic system here, that the blood, the capillaries, have the function of bringing in the nutrients on one side. On the other side, they also have the responsibility of carrying away part of the minor trash that is expelled by the cell. So on one side, you have in the blood all the homotoxins that you have in the body. On the other side, you have in the blood all the antibodies, because you have a totality of information in the blood itself. You have the hemolymphatic structure in there. And that is why this, they call it autosanguine dilution therapy, has been very positive and very active in the last couple of decades. And if you go through this book written by Dr. Reykjavik, you will see that in almost any kind of treatment, as much as he uses Traumel for almost anything, because I mean that's a miracle drug, he recommends the use of autosanguine therapy in a lot of conditions. And I would like to get the message across to you why he uses that and how effective it can be and how the mechanics of it really work. So one of the things we have to understand is that the volume of blood that we take out does not seem to play any role, as much as it doesn't have any significance if we use 1 drop of procaine or 150 drops. In major joints and in major terrains, we have to act with more volume just to be able to cover the surface. But I mean, the information, the repolarizing information that we obtain via the presence of procaine is obtained with 1 single drop. The same thing happens with the blood. If you take out 10 cc or 1 liter or 1 drop, it's not that what counts. It's just the message contained in the blood. On one side, containing all the homotoxins, on the other side, containing all the antibodies. So if the volume of blood does not play any role, we are being faced with a sort of bio-informative impulse, because it's not the presence of 10 or 20 or 30 cc that is counting. It's just a hint, the bio-information that we're providing, in which the volume does not play any role. And that is very important, because once the blood comes out of its hermetic circulatory system, it's out of there, and once it is out, we have, as I said it before, an inflammation. And inflammation is very important because the blood itself at that very moment turns into a pathogenic stimulus. And that pathogenic stimulus has to receive an answer from the body. I mean, you're knocking on the door and you have to receive some kind of answer. If we look at the autosanguis treatment from this angle, and we go back to our little chart here where we have the inspecificity and on the right side the specificity, it presents itself like a non-specific stimulus to elevate, to increase the defense responses of the body. That is more so if we accept the fact that that blood, philosophically being the carrier of soul and life, and physically being the carrier of the homotoxins and of the antibodies information, because we're dealing with tiny, minute amounts, then we can understand that this is a non-specific stimulus to activate, to trigger, to challenge the defense brigades of the body. The most recent research on immunology demonstrates that most of the immunological disorders are at a biologic molecular level, and that most of them do depend on the ability to recognize or not recognize a given invader. Let me put it in other words, which are more easy to understand. If the body has designated some guards, cells, or molecules that are in charge of keeping guard at the door, because we're having a private party in this body in here, I, chief commander of my defense brigades, say to them, okay, you only let the people in that have a tuxedo. And if they are higher than 5'8", you don't let them in. And they all have to wear glasses and a red tie. So you have the pattern, the exact pattern that was given as an input to the defense brigades at the door. They have the ability to recognize everybody because they have the pattern. And they select, and that's the selectivity that we don't only have at the cellular level, that's the same selectivity that we have at the intestinal level. And then the party starts, and we're all among us, the families here, all of them are 5'8", red tie, glasses, etc., and everybody's happy. But if the immunologic processes are screwed up, in spite of my repeating to those guys over there that 5'8" is the range in red tie, they start letting in 7'5" people, little people, fat people without no glasses, with yellow ties, and the disaster starts. So the inability of auto recognition, of immune auto recognition, leads to wrong immunologic answers. And what is a wrong immunological answer? It's an allergy. It's as simple as that. You react differently. You have a wrong immunologic answer. And if you have a wrong immunologic answer, it's better or easier to go to those guys and call them and say, come on here, I will repeat it to you again. The people you should let come in here to have these characteristics. And I will repeat it for the last time. Otherwise you're going to get in trouble with me. And I give them the specs again. I give them a new information. I give them a new input of information. Because that's what we do with the cell when we put some drop of protein, when we give them some homeopathic remedy, when we give them some good advice. We're giving new information. We're trying the cell to get to relearn a language it has forgotten. And then we send them to the door again, and we'll see that we will end up having a happy party because they finally relearned the specs of the people they should let in. That's what immunology is telling us in the most recent research. That ability to auto-recognize or to not recognize is what causes most of the immunological disorders nowadays. And if this immunological wrong answer translates itself into an allergy, into a wrong immunological answer, this immunological answer should not be the object of our work. Otherwise we're devoting our time to the consequences. The answer is a consequence. It's when we treat symptoms. You know? The eczema with cortisone, we're treating the answer. You know? We should treat the etiology. And if we retrain, re-educate our etiological factor, those answers will not happen again. And you saw it today when Arturo was showing his slides here, that when we talk about wrong answers, we are already on the right side. I mean, those people that come and say, well, I am allergic to this and this and this and this and this and that, as if it was very funny. You know, it's not funny at all. If you have become that allergic, you are way into this side here. Maybe you don't have a cancer yet. You don't have a degenerative phase yet. But you are in the neighborhood. You are in a fertile ground where maybe just one little push will be enough and you start your downhill race. So watch those problems of the people that are polyallergic. From homeopathy, we know that potentizing through succussion, or what we call the diamondization of an active substance, we are able to obtain an almost immaterial degree of information. I tried to explain it yesterday when we talk about ridiculous medicine and about solid ammunition. You know, when you're talking way above D23, you only have good wishes in there, if you want to put it that way. You know? Wishful thinking, as they say. But we know that if you potentize a given substance and you dilute it and you keep on potentizing, you obtain an immaterial part of an information. Otherwise, you wouldn't be prescribing remedies beyond D23. You know, that would be hocus pocus. This type of information, this subtle information, happens to integrate itself much easier to the living regulatory process of the body, out of the heavy language with a kick in the butt, which is what we do allopathically. We force the body into something that it might not even want to accept. As Bill was saying before, we haven't asked permission. We just invade the body and say, you cork, and that's it. You know? If we do it the other way, we say, okay, maybe we'll give you this substance and you take the decision if you want to stop the diarrhea or not. You know? That's different than just corking it and that's it. So this type of subtle impulses happen to integrate themselves much easier with this regulatory processes of the organism. And that's why we get to understand that working with autosanguis, minute doses of blood, and we potentize it, we have an incredibly efficient therapy. Since this autohemo treatment, or whatever you want to call it, the potentized, you know, you take the blood out and you succuss it. you can use whatever vehicle you want, saline solution, you know. You poultice your little tiny amount of blood and 2 cc of saline solution, you succus it 10 times vertically. Since this auto treatment, auto hemo treatment, the potentized one, with it, we're not only offering the body a non-specific challenge and stimulus, as we said before, we're also giving it a genuine kick for an appropriate auto modulation. And you remember when we were talking about transformation, modulation, and regulation. You modulate, you regulate, and you transform. So we're giving the body a genuine stimulation for immune modulation to go back and modulate the way you should be acting. And that can only be done if you allow the body to go first through the shock phase, then to the counter shock phase, and then to the phase of accommodation, because that's when you finally get back home and are ready to start your week again. Only if we understand auto sanguis or auto hemo treatment in this way, can we understand it as a counter sensibilization. And that's why we can also understand the therapeutic success that we can obtain with it. This autohemo, the presence of blood in our treatments, mixed with a non-specific or with a specific agent, acquires an enormous importance when we are dealing with chronic diseases, and very specifically when we deal with autoaggressive diseases. We don't need to go into details again what a chronic disease unchains at the level of our swimming pool, of our fishing or basic system. You already got that information. We know that in Reykjavik's book, page 15 of the Yellow Bible, he has the possibility, or he describes the possibility of doing this step-by-step autosanguis treatment. He has a little detail in there which is not liked by some people that do work with blood, because he suggests that we take blood out of the vein, we throw it away, and we just leave the dirt in the internal walls of the syringe. Some of them don't like the fact of throwing away somebody else's blood. You know. So they say Dr. Bolling, who knows a hell of a lot about fishing here, and whom I am just after to get some more information on in November, she says, you can do it in a different way. You just use as a base some broad scope medication, let's say Traumel, which is good for everything. You put it in your 10 cc syringe, you get hold of the vein, you inject the Traumel. If you want, you let a little blood as a reception committee come into the syringe, and you inject it into the vein, and before you withdraw the needle, let 1 or 2 drops come into the syringe. The volume doesn't play a role here. And that's your starting base. You already injected your base, and I'm going to give you 3 tips. I'm going to give you 3 tips on that, because you will run across these things next time you're standing in your office. Let's talk first about a chronic recurrent tonsillitis. We all have seen them. It's a daily bread. Mothers have gone with their kids with tonsil problems to their pediatrician, to the ENT, and you know all what they have given them. So this is a very known phenomenon. Let's talk about this specific case so we know that the base we use is Traumine. Traumine was used to be able to get hold of that little blood that we need in the syringe. And we better work with a 10 cc syringe because we need the empty space to do our succussions. And then, since this is called a gradual or a step-by-step autosanguis or autohemotherapy, let's look at the first step. In the first step of this treatment for a chronic recurrent tonsillitis, we're going to inject the fuel that is used for this area. This is called the Waldeyer ring, this is called the lymphatic ring, this is called the tonsillar ring, and we have talked these days about a specific fuel that has a biological appetite and preference for this area, and that fuel is lymphomyosol. Okay, what do we have here now? We have in our syringe, just a little tiny bit of blood plus 1 cc of lymphomyosol, that's the ample 1 cc. So we withdraw the syringe all the way back so that we have enough empty space, and then 1, 2, 3, 10 succussions. I mean, the blood that we have in there doesn't even flow. It's just dirt on the internal walls of the cylinder because there is not enough volume to be liquid. But it doesn't matter, the information is there because the volume doesn't count here. So that product, after 10 succussions, we pull it together again because it's only 1 cc. And then we give it subcutaneous or intramuscular. Or if you want to work at the level of the associated points, because you are directing your specific treatment towards the tonsillar ring, it can work. Or you can do it in wheels and papules. Or here in the back you have the acute-visceral reflexes. Let it be your option. The most frequently used is the butt or in the arm. But if you have more information and use it, please use your associated point or whatever you feel like you want to use. Okay, that is our first step. We take the needle out and then we go to our second step. I hope you understand why we use lymphomyosol. We're dealing with the management seat of the lymphatic happening of the body. And that lymphatic seat has been inhibited in its functions many, many times. Otherwise, we would not be talking about the chronic recurrent tonsillitis. So we go over to the second step. In the second step, we decide to take the homeopathic antibiotic. So we do that second step with Echinacea. Compositum. Here again, what do we have in the syringe now? Almost wishful thinking of blood, because the blood is already gone. You know. We have a little leftover minute of lymphomyocytes, succussed, potentized with the blood, and we now add 1 cc, no, it's 2 cc of echinacea compositor. And again, 10 succussion. And then we can go intramuscular or in the associated points. Mind you, up to now we have not mentioned any possibility of doing it intravenous. Let's stay at the butt or arm level or in the associated points. Then we go over to step number 3. Please pay attention to the mental steps that are taken here because they're very important. We have the best overall anti-inflammatory agent from a biological point of view as a base, very broad scope, good for everything. Then we're going to stimulate the flowing activity of the lymph because the lymph flows much slower than the blood, and if it gets even slower, then we have a catastrophe because then we have the lymph stasis, and if there is a lymph stasis, we have a blood stasis, and everything starts being staged, blocked, congested. The second step is just to act upon that same terrain with a homeopathic antibiotic, which is the echinacea. Now, since we're talking chronicity and recurrence, some organic damage to this part must have occurred within the last 3, 4, 45, 50 years, because we're talking about a chronic recurrent tonsillitis. And then the mental step to be taken here is, let's give the body the cement and the bricks and the mortar and the adequate means to see if it anatomically is still able to reconstruct or to repair the tonsillar damage that has been caused. And then I decide myself for tonsilla suis in jail. You see, the mental step here is an organotherapeutic step. Tonsilla suis in Yale. In Yale. I-N-G-E-E. This is injectables of Yale in Yale. Okay. So far, so good. I succuss it again. Yes, dear.
Why don't you
Well, because I want to be very specific. You know, the damage is at the tonsillar level. I don't want any additives. I want tonsilla alone. Because I want to be able to talk face to face with my tonsil, which has been under degenerative strain because of the chronicity and because of the recurrence.
I added that a tonsillar composite is a combination of several homeopathics designed to support tonsillar function. Tonsilla suis is a sarcode. It is a message, specific message of healthy tonsillar tissue. And by this step, you're attempting to regenerate healthy tonsillar tissue. It's the same name, but it's a different approach completely.
This is an organotherapeutic mental step. I don't want to activate the tonsillar function. The tonsillar function is activated by lymphomyocytes by removing whatever trash with my homeopathic antibiotic. Now I want to give the tonsil and alone the tonsil the possibility with the adequate, with the equalia, equalibus, not with the similia. I'm on the right side. I'm talking isopathic language. I want to give the tonsil the bricks, the tonsillar bricks, to see if she is able to repair the damage that have been caused by the chronicity and by this recurrence. And that's why I give it the SAR code or the nose node called tonsilla suis in Yale. Huh? It's 1 ampule, 1 cc. And again, I go, and don't forget the suppression. Now, I go to my 4th step. Yeah?
The small point, but I know that they have, for example, the catalog that they have Berber's well-recorded, which Berber is very good antibiotic. I'm just asking, how much information do you find that anything for that person?
God, I mean, please don't ever think that whatever we have been saying these days here is a dogma. I mean, if you feel out of your own experience, out of your own resources, that you want to make this a 7-step treatment, that you want to add echinacea plus berberis, and that you want to add tonsilla plus cutis plus mucosa plus whatever, feel free to do it, you know? Feel free to do it. Don't think that this is just a very rigid pattern. Not at all. So add whatever you think might improve, as long as it is the minimum optimum for the patient. So what I'm interested in getting across to you is the mental steps that have to be taken to do this here, because you're the one that are going to be the making the choice of whatever you want to do. In my 4th step, and when Reykjavik talks about the autosanguis therapy, he is normally talking about 4 or 5 steps, no more, maximum 6. And he is talking about the fact that in the last, before last, this is going to be 5 steps, starting at step number 4, you can include nosodes. Here we have a tonsilla in the 3rd, but that's not very categoric. But one of the things that you can go intravenous starting at on your 4th step. But look at the importance of this 4th step here. Here, and remember that we are confronting the body in every one of these injections with all the homotoxins contained in the blood, in wishful thinking concentration. We are confronting the body with all the antibodies contained in the blood in wishful thinking concentration. Plus with this element here, potentized every time, and the wishful thinking also potentized, because after every ampule that we add, after every remedy, we potentize, we succuss the mixture again. In our 4th step, we're going to confront the body, not only in a wishful thinking concentration, with the blood, with lymphomyocytes, whatever is left of it, with echinacea, with tonsilla suis, we're going to confront the body, possibly with the agents it has been retoxified in the last 2 or 3 or 5 or 27 years. We add penicillin in Yale. Because it is most likely that if this patient has presented a recurrent tonsillar problem, at some instances he was treated with penicillin. And we're using now penicillin in a homeopathic form to get the reversal effect, and we give it as a 4th step. Now, mind you, the steps do not have to be with one single remedy. You can have steps with 10 remedies if you want to. So it's not limited to one. Since we're approaching our last step, we do a double trick here. We are trying to confront the body with the agent that re-intoxicated it, most likely. It covered and disguised the pathology when he had a flourishing acute tonsillitis. They gave him the penicillin, and then it became chronic and recurrent. We're also confronting the body with the agent that the lab test found in these tonsils when they were flourishing. We confront that body with Streptococcus hemolyticus in Yale with the nodule. You can do the intravenous, but if you don't want to go intravenous, you can go ahead and do the same procedure we've been doing so far. So Streptococcus hemolyticus in Yale. Yeah, those are all those in Yales come in 1 cc vials. Now, if the patient, out of his history, tells you that he can remember that every time he had this recurrent tonsillitis, he was treated not with penicillin but with streptomycin. You don't use penicillin in Yale. You use streptomycin in Yale because that is also homeopatized within the list of homeopatized allopathic remedies, etc., etc., etc. What you want to add here, not forgetting your succussion. What are you trying to prove with this here? You're just trying to prove with this here that if you are able to confront the 2 guards on the door with the guy that they erroneously let come in here and kill 2 people in here, he might be able at a given moment to recognize him. This was the frustrating agent that was let in at a given moment when they intoxicated the patient. So you're confronting the body with a picture of that specific agent. That's why we have these penicillin here. And since this was the little animal that was suppressed, because they were ghost hunting, they were hunting in those days when they gave the penicillin or the streptomycin, you give the little animal also in a picture, in a subtle picture so that the body might recognize it. And if you want to give mercury, mercurium solubilis Hahnemanni, in Yale, again, just to flush the whole thing as a 5th step, good. And let your imagination, your intuition, as Bill said before, and your knowledge just play and add whatever you think would be of any help here. And just getting back to what Bill was saying before about the intuition, about the knowledge, I'll just give you my little pitch that I give every time when I give a lecture, is that we must never forget the tripoid that is of uppermost importance when we work with this type of medicine. We have to have in our first leg of the tripoid knowledge. And we have to be, unfortunately nowadays, we have to be very selective with the type of knowledge we acquired, because there are a lot of salesmen of illusion going around, convincing us of cure-it-all systems. So we have to be ourselves, we have to protect and ask God to give us a hand in protecting ourselves, not to fall into the hands of those salesmen of illusions that run around. So knowledge is very important. It is the first leg of the tripoid. The second leg is elements, working elements. If you go into the uterovaginal plexus of this young lady with a needle 3.5 inches, that is like a fishing hook, and you call yourself a neurotherapist, you'll come out with a lot of tissue hanging on it, and you'll cause damage. if you are going to work as a cardiologist, and you have an electrocardiogram that you made yourself at home, you know, do it yourself kit, you know, and you're going to take decisions based on the electrocardiograms that you get out of that device that you assembled yourself, you might be running a risk in the therapeutic decisions that you take, or the diagnostic decisions that you take. So the elements you use has to be the best possible. And the third element is to love the one with the one you do all the things you do. Because if you don't have love for whatever you do, if you don't devote yourself and just give all you have there and say, well, I'm going to keep this little reserve for the next patient, you know, because I'm still missing $150 today. You know, then you're not acting honestly, then you're not acting with love. And if you analyze this here, you will see that none of them works independently. Because if you have a chronic patient here, you can love him all you want. But I mean, he's going to keep on suffering. If you have only elements, but you don't have the knowledge and the love to really what to do with them, you won't be able to do anything. And if you have the knowledge, but no elements and no love, you're as stuck as you are with the other two. So this tripoint is sacred. This tripoint should never be forgotten. And I always warn people of this first issue here, because I happen to have the job of running around this world quite a lot. And I have run across a lot of salesmen of illusions, of lies. And if we buy lies with our honesty, with our love, we're going to harm our patient, because one of the legs of our tripod is going to be sort of unstable. So you can read the autosanguis therapy here on page 15. Maybe it doesn't have all the history that we digged out to put it together as a mini conference, but you will be able to find that it is not the mixtures that are important. Reykjavik gives you a lot of recommendations there in all kinds of pathologies. He says, autosanguis, do this and this and this and this and this and that. Don't take that as a dogma either. Add whatever you think you're adding. The important thing is here, the mental steps that you take to decide what should go in the first one, in the second one, in the third one. And one more thing that I can tell you. The base therapy, you almost play it safe if you go with trauma. Now Reykjavik didn't lose too much time in explaining his mental steps, unfortunately, and one has to go sort of in between the lines to fetch them, because he thought that everybody was supposed to know what he knew. He had another type of therapy that I've digged out in the last couple of years. When this type of stimulation, or when the left side of what I told you yesterday, the left cocktail didn't work, he worked at a specific, like on this side here, when he didn't have a specific response working with the cocktail of the left side, he said to himself, okay, let's do a pattern of hyper-immunization. And then he was thinking, I imagine, I'm just thinking aloud. When he said that to himself, he said, okay, I have to keep this basic system flowing, because the human being is an ever-flowing entity. The moment some of our flowing systems stop, we have a disease. And if they stop for too long, we're dead. So look the way he took his mental steps. He said, if we give organotherapeutic impulses, sarcotic impulses, to the organs of elimination that are the ones that are going to help us to reflow again, and we give them at the appropriate time, in specifically, just the whole bunch of them, we will have a hyperimmunation condition. And then he started off this way, very intelligently. 8 a.m. Vesica suis. 11. Kidney suis. 14 hours. Colon suis. 17 hours. Liver suis. And 20 hours pulmo or lung plus bronchi suis. As you see here, he's establishing a direct conversation with all the organs of elimination at their appropriate time, if you mind the organic clock. And if you mind the 5 elements. And he never saw this here. Never. Because I asked him so. I saw them at my place in Colombia and he said, my God, that's a very nice picture. What's this all about? He had never seen this here. In spite of that, he correlated just out of intuition, as Bill said. God knows why. Maybe somebody sort of was just whispering it to him in the back. But this is what he called the hyper immunization. And he does it one day, and that's it. And his trick was that he used this here. That is a little embarrassing, but you have to take the vein 5 times if you want to benefit of the presence of blood as an autonosode. You have to take the vein 5 times that day, at 8, at 11, at 14, at 7, at 20 hours. You mix 1 cc of blood with 1 cc of, this is our 1 cc ampules. You succuss them and you give them intramuscular, not intravenous, because this is only the first step, the first and only step, and you should not go intravenous before you reach the 4th or the 5th step. But to make it even more effective and to answer somebody's question from yesterday, you can do this at the level of the associated points. You can do this at the level of the head zones, and you can test it with the dermatron, and we have gone through that exercise. For example, you have a bad kidney reading, and it is not a deficitary reading, not an oocyst reading. You have an itis condition, an inflammatory condition, an excessive condition. You go and you inject the kidney in the head zones or in the associated points, and you go immediately, you test with the dermatron, and if it hasn't gone down to 50, or there might be somebody else ghosting around or shooting onto the kidney, it goes at least from the totally inflammatory condition to a semi-inflammatory condition. That is from 92 to 78. So you can use all those messenger services to carry this kind of information to the respective organs. And once you have gone through this here, and you allow at least 5 days the body to assimilate this information. Don't go the next day at him again and let's do it because we haven't had any answers yet, you know. This is a whole day's exercise. Allow the body at least between 4 and 5 days to digest, to relearn this information you are trying to reteach to him, and then make an evaluation again, and you can start with this side of the homotoxicosis state. Yes, Melissa?
You said that you read your blood each time for that versus the other one, you use the same spread to get the read. Why did you read wrong blood each time?
Because you have such a big time difference between one and the other, you know. That blood would coagulate in that time, so I mean you have the patient has to come at 8 and you ask him to come at 11. It lasts 2 seconds, you know. But in that case you have to pinch him 5 times, otherwise it would be bad. Okay, this is as much as I wanted to tell you about the blood.
On the autosanguineous part, you do the tromial first, get the blood, then you add each one of those subsequent remedies. Now, do you excrete all the remedy and just add the essence, or do you?
You know, you inject all the remedy.
Singly, each step.
Yeah, yeah. And what you have after you have injected all the remedy is wishful thinking almost, you know. But there is the information of the original blood, of the original tromelin, every time potentize, you know, of the lymphomyocytes, of the echinacea, etc., etc., etc. And make it to your habit, if it's possible. Whenever you deal with injections and you're sending homeopathic, ridiculous information to the body, use the vehicle blood, and you will see that the results are much, much better. Yes, Melissa?
Make sure that that's clear. Now, if you are drawing blood each time, it will actually be such a small amount left in the syringe after the first injection. You wouldn't even see the clot if it's in there.
You don't even see the color. Maybe you can see here.
So
After
would it be
this
more-
here, you don't even see that there was any blood in there.
Would it not be more potent then, the more it was bleeding down your scale, to keep reading the same syringe on your immunization kit?
Are we talking this side here?
Yeah.
No, on this side here, you have to use 5 syringes.
But I understand why.
Because the patient has come in at 8 o'clock in the morning, okay? It's 8 o'clock in the morning, and we're gonna go ahead with vesica suis, okay? I charge vesica suis into my syringe. You know, might be one way to do it. Or I get blood out of the syringe, out of the vein, I add my vesica suis, I potentize it, and I inject it in the blood. Bye-bye, sir. See you at 11. This syringe, technically there's nothing left in there, but I mean, more here than anywhere else. You know, you better get rid of that syringe, you know, before somebody from the FDA comes in and sees you injecting the same guy at 11 with the syringe you injected him at 8 o'clock in the morning. You know? So at 11 o'clock, the guy comes in and says, I'm coming for my second shot. Okay. You can use it. I mean, we all know that you can use it. And if you add a little protein to it, even more. But let's keep it the way Reykjavik conceived it. And then you take a new syringe, take blood out, you know, add your kidney, potentize it, and in the blood. As easy as that.
I can't help but notice that each one of the dilutions on the right side at 811.4 is basically a 1x. By the time you give the blood in the 4th step, it's out to a 5x. In the 3rd step, it's a 4x, 3x, a 2x, and a 1x. Each patient is individualized. Suppose the blood dilution they really need is an 8x.
Why not make an 8x of the blood and add each solution to it?
Don't ask me why they do it. They do it, but it is not a 1x. It is a 1x of whatever x you already have in the penicillin yield, in the tonsilla, in the echinacea compositum.
The first one is 1x, the next one's 2x, the next one's 3x.
No. Go ahead, Gary.
I've probably had, I've had considerable exposure to the combination injections that were mentioned yesterday, several thousand of them, and moved from that into the autosanguis injections. What you find in the lymphomiaside echinacea are combinations not of a 1x to begin with. There are several different potencies that run up the scale to about 200 in the NGOs. Now, when you're doing this dilution, it is absolutely not a 1x. You're talking about a single drop of blood or something like that. It's more in the range of a Korsakoff dilution, perhaps 50,000 to 1 or something like that. And if you're talking about subsequent Korsakoff dilutions, yes, you get subsequent Korsakoff dilutions. Now, how far do you run this out? He's talking about 4 or 5 steps. How far do you run this out? I found that each step you went to, the combination became more and more powerful. So much so that in one particular case where we got to the 6th injection, there was projectile vomiting, even though the patient had no ill feelings whatsoever before or after the vomiting, and got tremendous warmth that came to the thyroid area, and a resolution of a chronic, long-standing hypothyroid condition. And this is all within the space of about 15 minutes. So what you're getting is not a simple 1x, 2x, 3x solution. You're getting a complex of things that I think a physicist would have a real difficult time computing as far as the dilution is concerned. And there may be a better way of computing that or figuring that or evaluating what would be more appropriate, but that's a complex that's far beyond the average practitioner's ability. One thing that I would add to this, what we found that made a significant difference, we added an additional step or two at the bottom, and that would be that we added coenzyme compositor for the stimulation of the citric acid catalyst enzymes. And in addition to that, ubiquinone, which increased the uptake of metabolic oxygen at the cellular level. And those were two that came for us to be indispensable, because we really saw a significant difference when those were used at the tail end, as opposed to the responses we got with a basic program like this.
Can I ask, Gary, in your experience, have you ever used this kind of procedure on someone who, for example, is a cancer patient and they're developing chemo and explantation therapy?
Yeah, what you do is use more directed anti-chemotherapeutic agents, and there are. I once did a complete protocol for an infant who was undergoing chemotherapy, and I found that there were probably 30 different anti-chemotherapeutic agents that we were able to include in that type of therapy. And one of the variations that you can do on this, it's not recommended in every case, of course, each is individual, but what we found that was very quick and easy to do and got tremendous responses was to use a butterfly. And from step 1, or use a butterfly, put the trachea in, and from step 1 then, draw out, use a drop of blood, take the syringe off, add your ampule, inject it intravenously, and then subsequently go through the steps like that. And you could go healing reactions. Yeah.
Because you're coming in with the agents again, you know, potent ties.
But you can wait a week later after your
Oh, yeah, of
pathways
course.
are open.
You
A week
have
later,
to
you
wait.
can start.
You have to wait because this is quite a language to learn again if you have forgotten part of the alphabet.
Yeah, the reason I ask is because so many people advocate waiting longer because they say the body just isn't ready for it in that short time.
How long first was clear over on number 6 on the table that you had diagnosed or not treated yet? How long happened? What chance do we have?
Well, I mean, this is what we were talking about at the breakfast table this morning. Let's say you have a patient here on the right side. And Arturo has this many of these patients. And maybe we get to see more of those patients than you guys get to see here. Because in our place, they're kicked out of the hospital because they need the bed for somebody that has a chance. You know? Yeah, and has the money to pay. You know? Those patients, if nothing has been done with them, what happens? And if this is a general rule for patients under degenerative strain, those patients cannot allow themselves the luxury of having any kind of dead teeth. I mean, every dead tooth, it might be a root canal treatment made by our friend Aoi, you know, it has to come out. Because the root canal treatment is perfect, but the death of the tooth is also perfect. Because let's remember that the tooth is Fishinger's basic system too. Okay, those patients cannot allow themselves the luxury of having any metals in their mouth.
Gold?
Huh?
Gold?
Not even gold. Because at that age, at that level of energy, any kind of metal suck off energy. Those patients have to have a change in diet. Definitely. And maybe Arturo will have some time tomorrow to give you some hints on the type of diet they must have. There is a lot of fanatism about diets nowadays. You know? There is a golden middle line for patients that are under cancer and the degenerative strain. But there is a change in diet. There is a change in lifestyle. I mean, with a patient that is already at phase 6, you cannot say, okay, you go down from your 120 cigarettes down to 20, please. No more. No, 0. You know? I mean, there is no time to compromise at all. Either you take it or you don't take it, and they take you. You know? You have to start filling the batteries of this patient because they're empty. So you have to give them a lot of IV drips with saline solution, with procaine, and then you start adding, once you fill all the cells of the battery, because the patient that is here on phase 6 has an empty battery. All the cells of the battery, like in your car, are empty. So the car is just about not to work anymore. Once those cells are filled, you can start giving him specifically. We don't worry about the cancer yet where it is. It's there. That patient has a diagnosed cancer. Let's not ask for the name of the cancer, of the organ, because it is pandemic mostly. 5 cc's of protein, then you can start adding glyoxal. Glyoxal, and you can look it up in your yellow book, is one of the agents that stimulates regenerative processes. Then you can go ahead and use your right-sided formula with gallium coenzyme, viscocomposite, ubiquinol, sorinohyl, heparcompositum. A couple of times, maybe 5 days in a row. If you have the ability, and I'm just talking about the protocol that Arturo follows, that most of the guys that have been with us in the last couple of years are following back home. Those patients receive for at least 4 or 5 weeks, every day, 40 cc of intravenous oxygen. As it sounds, 40 cc cc of intravenous oxygen. Intravenous oxygen doesn't cause embolia. Intravenous oxygen regenerates the blood, stimulates the formation of eosinophils, and brings back, confronts the body with that primary information that we need since we come onto the world, which is the oxygen information. Just to tell you how that oxygen goes into the blood, it's a little machine called the oximeter, which you graduate how many cc you want to flow per minute. Normally you put 2 cc of oxygen inflow per minute. And if you have them per minute and you try them out in a glass as if it was the vein, you put the butterfly here and you start graduating your device and you see that little pearls come out like a fish, you know. And all that adds to 2 cc per minute. It never becomes a column of oxygen. That would make it cause an embolia. But when the second pearl of oxygen comes, the first one is already up here. You know? And when the third one comes, the second one is already up here, so they never get together. That was the oxygenation therapy that was invented by Dr. Helmut Regelsberger in Germany. And I mean, I just couldn't praise it enough to tell you how much you can do in degenerative patients with this here. And then you can add it all, the whole treadmill that you might have as therapeutic tools. Maybe it's not the glyoxal, maybe it's not the gallium, maybe it's not the oxygen, maybe it's not the all these organs that are going to cure the patient of the cancer. I'm not stating that. What I'm stating is that changing the rules of the game in such a drastic way, nutritionally, from the O2 point of view, you're supplying a body that is dying of lack of oxygen with sufficient oxygen. From the point of view of fixed costs, you have removed all the fixed costs. That patient doesn't have, I mean, all the fields of disturbance have to be injected. The patient maybe has to change his bed because he might be sleeping on a geopathic zone. Also that has to be cracked in, if at all. So you're changing the rules of the game. That cancer is happening so much that suddenly the cancer looks around and says, God, I mean, I don't have any fertile ground to progress anymore. I better go back. Maybe they call it, as I said the first day, a spontaneous remission. Who cares? Do you think the patient will care about what they label him with? Spontaneous remission or miracle or ghost work or whatever? No, it doesn't count. So that's the way we approach a patient like that, with the whole battery. Yes?
Can you get that machine?
That's, I can mail you the address. I don't have the address on me, but I can mail you.
Is that ionized oxygen?
It's pure medical oxygen. It's like a mill, you know.
We have a book in, a hot book on ozone, and I think that address might be in that book.
No, that book is by Rilling and by Dr. Feban. It's not in there. I'll get it to you, Gerard, to you, and you can pass it around.
Right. Is it ionized oxygen that you could make somebody hyperconscious or hypo, bring them up or bring them down by changing the ionization?
It is pure medical oxygen like the one you use for any kind of oxygen treatment, for breathing oxygen. It just goes through the machine. The machine is like a mill, you know, and it extracts the oxygen from the pipe or receives it and then dosifies it according to the graduation that you make. No, you inject it intravenous. That's why they call it oxygenation therapy.
I'm not that specifically about the infants, but it seems like theoretically, since you're using this autocyclist therapy and your homeopathics, that perhaps I'd be particularly good for the community experience or something like that.
paciente que con leucemia, donde tú estás haciendo este abordaje con los remedios, con toda la batería, ¿no? ¿Qué otro medicamento se le puede agregar? El ciclo de Krebs tiene que entrar. The whole box of the Krebs cycle has to be crammed in here before, during, and after the treatment, because that is screwed up like hell. I mean, that's the body's chemistry. And all the viscum, as you know, on the right side, on our right side cocktail, we have a mistletoe, you know, and you have 3 different types of mistletoe in Hilo. One is the normal edition, the medium size in strength edition, and the forte or strong edition. What does the forte mean? That it starts off in its mixture at a lower potency.
Todos los pacientes de cáncer, como necesitamos la desintoxicación del hígado, entonces hacemos durante diariamente, meses por meses, los enemas de píldora de cáncer.
You remember that in our left-sided and in our right-sided cocktail, or I mean right-sided and left-sided cocktail, number 1 and number 2, you know, we have in both sides our liver activators and our liver regenerator here with hePAR. Because one of the first things that is really stuck when you are going down the drain is your liver. I mean, the detoxification, the process of the body is stuck, it can't work. And then for weeks we use enemas with coffee, Colombian coffee.
Juan Valdez.
Juan Valdez coffee, yeah. On a daily basis. On a daily basis. 1 litro y medio, ¿no? Ponerlo aquí. Ponemos la vuelta.
While they're discussing the blackboard here, or the whiteboard, we're going to break for an hour, and then we're going to come back here as soon as they finish. Please go up to 350. We have a little bit more to eat up there this time, so you can have a little snack when we get back here in one hour after they conclude this. And we have Bill Morris here, and even Bill, you're welcome to come up and have a little refreshment, so we can put you in fine form. And I've been prepping these people. We have, I gave them all your essays, so if they've been doing their homework, they know about the evil empire, and they know about the woolly booger, and they know about the politics of healthcare. So you tell us what we can do to see your ideas become reality.
We won't be more than 2 hours in just a minute.
Well, wait a minute. Gary's got some Bray up there. He's not going to wait for you.
Alberto, let's be sure that we answer Liz's question. She's asking about clinical responses of leukemia.
No.
What I have found in leukemia is that there's such a pressure from the community here to deal with leukemia from every direction that they get a lot of chemotherapeutic agents along with whatever therapy you're doing. Now, the best that I can say, based on what I've worked with in leukemia, is that I get, as long as I have them under homeopathic therapy, I can see energetic changes. I can see improvements in energetic function based on the EAB. But what I have had a very difficult time doing is keeping them away from the Orthodox community, where they're constantly being drawn to do the good medicine, the really powerful stuff, quote unquote, that's going to make them well or keep them alive. And so I can't really state with any affirmation that we have had a resolution in leukemia based on this therapy. Have you had any experience with that?
Vamos a concentrar un poco más la pregunta. Lo que está preguntando Melissa es ¿qué resultados se pueden ver con este abordaje de pacientes con leucemia? Porque dice Gary que aquí hay tanta locura con la cuestión de la leucemia que realmente al paciente con leucemia lo están jalando a cada rato desde el punto de vista de la podología, y en vez de una cantidad de venenos, tú lo dejas libre un ratito, ahí viene donde ellos le hacen con esto un par de cositas. Energéticamente se ve un punto de mejoría.
y ojalá pudiera conseguir alimentos orgánicos libres de pesticidas, herbicidas.
Okay, let's get started with my protocol on a leukemic patient. My very first step for that patient is a diet. It has to be on raw foods and, if possible, organically grown, if it is possible at all, or anywhere.
Y lógicamente no proteína animal.
If you're talking leukemia, you're talking a protein digestive problem up to some extent. So this patient cannot see animal protein even in pictures. So no animal protein at all.
Es decir, simplemente por medio de un análisis de la dieta, buscamos que el balance de aminoácidos sea correcto.
Just analyzing the diet, we try to balance out the amino acids, then we don't have any problem. That patient will not suffer any kind of deficit because we're trying to balance it, analyzing the diet, the missing amino acids, if we give them a supplement.
Segundo, hacemos una terapia ortomolecular. ¿Cómo? Primero, hacemos un análisis.
We go then with orthomolecular medicine, starting out with a hair analysis.
Y de acuerdo al análisis, hacemos un tratamiento IV de los minerales.
And according to the hair analysis, we do an IV treatment of the minerals that are needed.
Que estén en tercero y segundo grado de deficiencia.
And we use first those minerals that we find in the hair analysis in third and second degree of deficiency.
Coincidencialmente, yo utilizo el laboratorio Dr. Data que hizo esta mañana.
We use the same lab doctor's data that I get somebody from this morning.
Excuse me, what type of mineral analysis do you use? Paxel or what type do you use?
¿Qué análisis de minerales usas tú?
On the IV minerals.
En los minerales, ¿qué tipo de
¿En qué pongo? Ok. En Alemania, en Weimar, conseguimos los de moros, que son sulfatos o gluconatos de zinc, manganeso, cromo, cobalto.
We buy them from Weimar. Weimar is a little pharmaceutical house that's next to.
Okay, I see. Analyze deficiencies by hair analysis only.
Yeah.
And then introduce the minerals in third and second degree. Okay.
That appear to be deficitary in the third and second degree, according to the hair analysis.
Entonces pongo endovenoso.
That's intravenous.
Y hago por vía oral
Orally,
un balance con vitaminas,
I try to make a balance with vitamins,
aminoácidos
amino acids,
y cualquier otro nutriente que considere importante.
and any other nutrients that I might find of importance for that specific case.
Durante la fase de ataque, aplico una solución diaria de 250 centímetros cúbicos de solución salina con de 8 a 10 gramos de vitamina C intravenoso y 5 centímetros cúbicos de DMSO, dimetilsulfoxi. El dimetilsulfoxi es un cruzador de barreras que me permite meter estas grandes dosis de vitamina C a las células. Esto de acuerdo a los estudios de Pauling y Cameron.
This, according to the Pauling studies, I go ahead then with my vitamins and amino acids, and during the attack phases, I use 250 cc of saline solution with 8 to
Los enemas de café, todos los días,
The coffee enemas every day
por 1 year.
for 1 year. You're dealing with a very severe condition.
El café utilizamos en un pocillo de 3 a 4 cucharadas coladas. O sea, eso queda una pintura.
And this is coffee almost, mother tincture, because in 1 cup we use 3 or 4 spoons, not of Nescafe, of green, solid,
Natural
good,
coffee.
Juan Valdez, Colombian coffee, natural coffee. No, it is a black, really black coffee, almost tincture.
Este café colocado en el recto es absorbido por las venas hemorroidales, por el sistema de la mesentérica al sistema portal, y en 7 a 10 minutos tenemos una invasión de cafeína al hígado. El hígado reacciona produciendo una hipersecreción de ácidos biliares. Y nosotros sabemos que los ácidos biliares es la forma como el hígado saca las homotoxonas. Además, esto alcaliniza el duodeno, lo cual mejora la condición intestinal del paciente.
This coffee rectally applied is absorbed by the hemorrhoidal veins, by the mesenteric veins, towards the portal veins, and in 7 minutes we have an invasion of caffeine in the liver. The response of the liver is a discharge of biliary acids. This discharge of biliary acids, we all know, produces an alkaline condition. And the more alkaline we get at the duodenal level, the less chances we have to have malignant formations or progressions which need an acid base.
Además, esta secreción de ácidos biliares me permite desintoxicar realmente el hígado.
And this secretion of biliary acids is the one that really helps me detoxicate the liver.
Como tercera fase, procedo a hacer la IABDM, la medición, para determinar la homeopatía que el paciente necesita.
As a third phase, if we're talking phases here, I do only then the EAB test to see and to determine the homeopathic approach that the patient is going to be needed as of then. Because the test here would give me just a big dark cloud, and I'm not even able to see through it. First, we detoxify the patient as much as we can, and then here we do the EAB test, as we said, to determine the nosotherapy and accompanying drainage homeopathic remedies that we're going to supply the patient.
Es posible que aquí surja algunos nuevas áreas de ataque con terapia neural que en la historia clínica no estaban claras.
It might be very likely that when we do the EAB test here, that some new areas of attack might pop up that we have to tackle with neurotherapy that didn't come out while we were working out our clinical history. Because once you have, through these approaches here, once you have removed a lot of trash, other parts of the iceberg become visible.
How often do you use the IV drip with the PMSO and the soda
El ácido sodio sórdico trata de
Esto lo pongo, recibo al paciente los primeros 15 días diarios
the first 2 weeks on a daily basis,
y después 1-2 veces a la semana de acuerdo a cómo vaya evolucionando el caso.
and then once or twice a week according to the development of the patient.
Pero de todas maneras, cuando paso ya a ocasionalmente, diariamente le toma de 4 a 5 gramos por día oral. Allí uso los ascorbatos para evitar molestias y porque además son ascorbatos de zinc, ascorbatos de manganeso. Uso los ascorbatos de las deficiencias que él tenga en minerales y así evito molestias gástricas.
After that, I continue with ascorbates, oral ascorbates of whatever deficiencies he has in his hair analysis, I use those ascorbates because they avoid having this stomach upset that you might have with stronger substances.
Durante todo este tiempo hago una terapia neural por lo menos una vez a la semana total para vertebral, para mantener un estímulo y uno de los puntos de asentimiento.
During all this time, I do at least once a week a non-specific neural therapy along the spine, all the way from the top to the bottom, just interesting in knocking and challenging those associated points. In other words, the organs.
Siempre estos pacientes vienen siendo apoyados con psicoterapia, ya que definitivamente el paciente canceroso tiene un patrón emocional específico, pero trabajamos únicamente con terapias humanísticas, básicamente como rolfing, o trabajamos también técnicas de meditación, técnicas de relajación, es decir, todo lo que pensamos que está dentro de la parte biológica de la psicología.
The patient with cancer has a very specific and fixed mental pattern. That's why this kind of patient, we always give them throughout the treatment a psychotherapy. We work with Rolfing technique or with any kind of meditation without letting it fall into any kind of religious tendencies, because he needs a very serious backup from an emotional point of view.
La experiencia que tenemos es que si al menos no podemos hablar de que se curen los pacientes, la tasa de sobrevida es mayor que la que el paciente tenía sobrepuesta, pero principalmente la calidad de la vida para este paciente mejora notablemente y logramos en la mayoría de los casos que el proceso se quede en un stand-by.
We would be lying if we would be telling you with this kind of approach and you've got it, I mean, they'll all be cured. No. What we have obtained with this type of approach is that the quality of life of the patients improves substantially. I mean, there is not a comparison possible. The prolongation of the lifespan is much, much longer than what he came in to see us. Because if you're talking about this patient that Melissa is just painting here, they normally come to see you when they have 5 or 6 or 8 month life expectation, because that's what they have been told on the other side of the street. Or 2 months? Okay, 2 months, you know. And if you prolong that, but not prolong it at the intensive care unit at $50,000 a day, you know, you prolong it with biological means, with a good psychotherapy, in a biological way, and you add quality. And quality is what is being missed when you're dealing with cancer patients nowadays. Quality of life.
En los últimos tiempos hemos podido ver que este tipo de terapéutica aplicadas en fases iniciales del proceso canceroso, o en pacientes jóvenes, o en pacientes que todavía tienen capacidad de reaccionar, se catalogarían como regresiones espontáneas.
We have seen that this type of approach, and this includes what we mentioned before, you know, removal of all fixed costs like root canal treatment, implants, etc. Applying this here to younger cancer patients or to patients in the beginning stages of their problem, when the capacity of response is still there, when they don't have a total paralysis of regulation, you might find a very substantial number of, let's call them remissions, with patients approaching them this way.
Y en aquellos cánceres terminales que hemos recibido, hemos visto un paciente apagarse, morir en buenas condiciones, y generalmente son grupos familiares que toda la vida nos agradecen ese feliz terminar, porque de todas maneras, si la función del médico no puede ser curar, al menos debe dar dignidad a la muerte.
And don't think that we have had only patients that come in, the second day after they were diagnosed. We get terminal cases where you know that in 10 days, in 2 weeks, it happens. In those cases, we follow exactly the same routine. Those patients die after 10, 12, 15, 20 days. But the quality of the last days is something that makes that their families stay with us for the rest of their days, because our obligation is not only to cure or to heal, it is also to give dignity to the last days of a patient if we're not able to cure them. Okay, I think.
Let's get some dignity. We'll come back here in an hour. What time is it now? All right, 8 o'clock.